So welcome everyone, and thank you again for joining. I'm Mara Herman, and I'm the Health Outreach Coordinator here at the Ecology Center. I'll be your moderator for the evening. Here is our agenda for this evening. Currently, all attendees are in listen-only mode. If at any time during the webinar you have a question, please use the chat box to share it. After our presentations from Dr. Schettler, we will have time for questions. And with that, I'm going to first turn it over to Rebecca Munich, our Deputy Director, to talk a little bit about some of the toxics-related campaigns that are happening here at the Ecology Center.
Okay, can you hear me now?
Yes, we can hear you.
Excellent. And then Mara, you'll do the learning objectives after this, correct?
Yes.
Okay, perfect. Let me just get this slideshow going. Okay, so we wanted to take a little bit of time tonight to give you a little of the context for Ted's presentation with his particular focus will be on phthalates and flame retardants and some of the policy issues and various contexts at sort of the national level, and we want to dig in a little bit on some of the campaigns that the Ecology Center is engaging on those issues. And part of this will tee folks up for those who are doing toxics practicums for some of that work. But before I dig in a little bit on the campaigns related to phthalates and flame retardants, I wanted to give some updates on the work that we have been doing on working to virtually end childhood lead poisoning in Michigan, and all of the terrific activities that you all have done via the Lansing Day and our upcoming activities on the media training coming up in a few weeks here. The first thing I wanted to mention is that for some time I've talked about the state's lead commission and the action plan, which was released earlier in the spring. And there are a number of different public forums, and I have 3 of them up there on the screen. We just missed one a couple of weeks ago for anybody on the west side of the state in Grand Rapids. They had some there, but we have a couple more coming up, and there actually is one in Health District 10, so I'll get that information out to you too. That was organized recently. These are a way for you to learn a little bit more about what the action plan is for the state. That includes activities on funding and public policy, like some of the ones that we talked about during our Lansing Day, and so on. I would highly recommend, if you're available to attend any one of these, to do so. That is something that, again, you can count towards your practicum hours as well. I am planning to be at the one in Jackson tomorrow and the one in Detroit. I don't think I'll be able to make the one in Traverse City, but if things change, then I would be happy to be there. And there may be some webinars on the action plan later in the summer. As folks may remember, these are some of the talking points and our key pieces that we highlighted at our Lansing Day. They will also be key talking points for the media training coming up. I wanted to highlight a victory here and thank you all for the advocacy work that you did in Lansing with us on our Lansing Day. Because of the tremendous support that had been coming out to make sure that we had full funding in the budget for various activities, the Child Lead Exposure Elimination Commission actually came away with $1.25 million in the budget, which is a huge victory in what we asked for. Originally in the House, that had been cut to $675,000, so having that additional money means we can fund more primary prevention activities, education, and other testing activities there. Additional funding requests went through for the Michigan Department of Health and Human Services and their funding of abatement programs and other services for children who are discovered to have elevated blood lead levels. So thank you, a big victory there. But as we switch gears to talk about some other different types of toxic chemicals, I want to focus on 3 different sort of general campaign areas and how they relate to the topics of flame retardants and phthalates tonight. So one of the things, if you remember all the way back to our orientation day in the fellowship, we talked about different strategies that can happen at a local level, or even within certain institutions like healthcare institutions, to make a concentrated effort to purchase products that don't contain toxic chemicals in them. And as we hinted at the orientation, Ann Arbor was on the cusp of signing their environmentally preferable purchasing policy, and that has happened. The Ann Arbor city manager signed that this spring, and this really is a huge victory. We are looking to celebrate that and roll that out to some other cities in the fall. And this is what a leading municipal policy that contains language on flame retardants, phthalates, perfluorinated chemicals, heavy metals, antimicrobial chemicals. We're not going to cover all of these today. Ted's going to focus on flame retardants and phthalates because there's a wealth of information on all of these products. But this is something that we wanted just to give you a bit of a teaser that will continue on, and there are other municipalities where we could make some progress, hopefully this year. There are 7 different cities across the state that are currently involved in a Green Communities Challenge in the state, and we would like to be able to roll this out and have folks in that Green Communities Challenge also consider putting together environmentally preferable purchasing with good, strong toxics language for their cities. The same things can happen, as I just mentioned, in institutions like healthcare institutions and hospitals or school districts. So those are other possible ways to think about practicum projects as we start introducing more of those campaigns to you. So that's one piece there. The next one is a campaign that the Ecology Center has been working on for quite some time, and Lauren is really truly our expert on this, but getting toxic chemicals, particularly toxic flame retardants, out of children's car seats and other children's products. And over the last couple of years, actually over the last 6 years, we have been making more and more progress, and in 2017, the first children's car seat without any added flame retardants was introduced, the Mesa Henry by UPPababy on the market. We have a new study coming out in, I believe, September of this year. We have the car seat detox campaign, and there are lots of different activities there for folks to engage on in terms of market-based campaigns, working with retailers and manufacturers to get them to move out of toxic chemicals in the products that they make or that they put on their store shelves. In addition to children's car seats, we will be doing a crib mattress study, kicking that off in the fall as well. And so we'll keep you posted on that as that develops and what activities you can become engaged with there. For example, last year we had, as you can see here with this petition, obviously there's educational activities and talking to folks about these activities, helping us gather petition signatures or deliver them. We worked with some learning disabilities advocates in Atlanta last year to deliver over 42,000 petition signatures to Graco Children's Products for this campaign. And then the other chemical du jour today is phthalates. Phthalates, as you're going to learn from Ted, are a very common class of plasticizers, chemicals that are added to plastics and cosmetics and all kinds of different products in our homes and our environment. And unfortunately, they are so ubiquitous in the environment that they end up in our food. So this is a little picture here of a New York Times trending article from our mac and cheese study last year that Lauren and the Healthy Stuff team put together with national partners. And we found that processed cheese products had high amounts of these hormone disrupting phthalates in them. And we launched a campaign to call on Kraft, Heinz, Kraft, to explore their supply chain to find out where their products are being contaminated with phthalates, and to try to move out any processing equipment or things like that that may be leading to that higher contamination. We have a study underway right now looking at some other food products. Like you can see the picture there of the Lunchmates, so Lunchables products and those convenient kid-friendly foods, so to speak. We're working with a couple of labs right now to find out about phthalates in those products. So that will be coming up as well. It's on a little bit longer of a timeline perhaps than the car seat campaign, but we'll keep you posted as things continue on the phthalates in food campaign. I don't have a photo for the next bit, but over the years we've also worked on toxic chemicals in the built environment, like via home improvement products, and that's another campaign on the market side of things where we'll be targeting some of the nation's top retailers. There was a major victory on another class of chemicals we won't focus on that our partners on the Mind the Store campaign led to get Lowe's to commit to moving out of methylene chloride, which is a toxic paint remover that has very acute toxic effects and can lead to death from exposure from, folks who are doing DIY home improvements or workers. So some important campaigns there too. The building products campaigns and studies will also have a heavy focus on phthalates and flame retardants because of how common they are in those products. So that's just a little bit of a teaser on some of these different campaigns. So we have the public policy side on lead, and then at the municipal level on some environmentally preferable purchasing, dealing with phthalates, flame retardants, and other chemicals. The institutional purchasing side of things for hospitals on those same classes of chemicals, and then the market campaigns on phthalates and flame retardants. So with that, I'm going to turn it back over to Mara.
Great, thank you, Becca. So for tonight's presentation, our learning objectives are, after this presentation, you will be able to identify at least 2 negative health impacts of phthalates and flame retardants, and also be able to identify an example of regrettable substitution of one harmful chemical or class of chemicals with another harmful chemical. Which brings us to our presenter for tonight. We are super excited to be joined by Dr. Ted Schettler. Dr. Ted Schettler is the Science and Environmental Health Network Science Director. He received his MD from Case Western Reserve University and a master's degree in public health from the Harvard School of Public Health. Dr. Schettler has worked extensively with community groups and non-governmental organizations throughout the U.S. and internationally, addressing many aspects of human health and the environment. He has served on advisory committees of the U.S. EPA and National Academy of Sciences. He has also authored and co-authored several books and numerous published papers addressing human health and the environment. Among many others, his current projects include serving as science advisor for the Healthcare Without Harm Coalition, contributing to its international campaign to improve the environmental performance of hospitals and other healthcare institutions. And with that, I'm happy to turn it over to Dr. Ted Schettler for tonight's presentation.
Thank you very much, Mara, and thank you, Becca. It's a pleasure to be here, and thanks for the opportunity. Let me get this in slideshow. There we are. So I'm going to break this presentation into 2 sections, as Becca mentioned. I'm going to talk about flame retardants first, and then if you have some questions at that time, we can take them, and then I'll move into the second part, which is about phthalates. So just to sort of create some context here, this is just a sort of a menu of examples of products that are treated with flame retardants, and you can see how widely they are used in consumer products, from things that are in our homes like our furniture and building products, and then appliances, electronics, and various things, baby products like the sleep positioner shown here. And we also just heard about they're being used in car seats and so on. So anyway, they're very widely used. And I just wanted to take a minute to talk about regulations that govern their use, because this is an important historical context for understanding what's been going on for the last few years. And what you see here on this slide is that there are a number of different organizations, states, agencies, and so on that regulate flame retardants in a variety of products, like in furniture, electronics, textiles, and building and construction. And among the most rigorous regulations that have been responsible for flame retardant use is what's called the California Technical Bulletin 117, which addressed the flame retardants in the foam in furniture in our homes, and then California Technical Bulletin 603, which addresses flame retardants in mattresses. And then there's a federal mattress flammability standard, and then electronics and textiles are regulated through other agencies and policies. But the important point that I want to make here is that California had particularly high standards for flame retardants in furniture and in mattresses. And what that ended up doing was driving the entire national market for the use of flame retardants. And particularly important was Technical Bulletin 117, which required a 12-second open flame testing for polyurethane inside of furniture. So, for example, the foam cushions on your couch or in your pillows and so on had to meet this rigorous 12-second open flame testing requirement, which ended up requiring that the foam get loaded up with enormous amounts of flame retardants. I mean, sometimes it was as much as 40 or 50% of the weight of the product was a flame retardant. Because of some advocacy and new science that developed over several years, it was actually shown that this kind of flame retardancy was absolutely not necessary in order to protect people and their property from fires. And so in 2013, TB 117 was revised and in a way that required much less in the way of flame retardants. And the implications of that were felt not only in California, but entirely across the country, because now manufacturers could make products with lower levels of flame retardants that would meet safety standards, and they did that quite readily. Well, why are we even concerned about this? There are a number of exposure pathways for flame retardants that have been clearly demonstrated in people, and I've sort of summarized them here on this slide. You can see, for example, that you get this flame retardants in consumer products, but in most cases they're not bound to the material in the consumer products, so they get out into the environment and result in an indoor exposure, which then, as we'll see, can result in inhalation and ingestion. If it gets into the sewage system, the flame retardants, they go out into the biosolids and then get spread on agricultural land and can make their way into our food, which indeed they do. Some of the higher levels of exposure came from eating fatty foods that were contaminated with fat-loving fire retardants. They can also get into waste streams that come from, for example, electronic waste or shredders, and then get out into the environment. And so you can see there are a variety of ways that they get out into the environment and then into people. And some of them, as we'll see, were bioaccumulative, and because they're fatty-loving and bioaccumulative, ended up at particularly high levels in breast milk, which was a major source of exposure for nursing infants. Now, I want to talk about the organohalogen flame retardants to begin with, because I think that they're very instructive, although their use is declining for reasons that we'll soon begin to see. Organohalogen, meaning it's an organic compound that has a halogen on it, and for the purposes of flame retardants, the halogen has typically been either bromine or chlorine. So that's what we see here in the first bullet. And then as they moved away from the organohalogen, the particularly troublesome organohalogens, they moved more to phosphate flame retardants, which I'll also briefly describe, but unfortunately some of them also are halogenated. So we still have the problem with their toxicity. You may be interested in the mechanism of action. it was curious to me as to how putting bromine or chlorine on a molecule contributed to its flame retardant properties. As it turns out, what happens is that as the temperature increases, the bond that links this halogen, which is either bromine or chlorine, to the molecule is broken. And when free bromine or chlorine is released from the molecule, it's a very reactive compound and scavenges free radicals very rapidly. And if you do that in a fire, it reduces the potential of the fire to propagate, so the fire tends to smolder out. So that's the mechanism of their action. Now here, I wanted to show some similarities among various chemical structures, so that to help contextualize this. On the top here is polychlorinated biphenyls or polybrominated biphenyls. Those of you in Michigan who remember may be familiar with polybrominated biphenyls because of the animal feed contamination that happened in Michigan back in the 1970s, which resulted in widespread human exposure to contaminated meat. And the difference between the polychlorinated biphenyls and the polybrominated is simply that bromines or chlorine are put on the benzene ring here in varying numbers. But now we move to the flame retardants. Here in the second image in this panel, polybrominated diphenyl ethers. And the only difference between them and the ones above is that there's an oxygen here creating an ether linkage between the two benzene groups. But then they got populated with varying numbers of bromines around the benzene ring, just like the polybrominated biphenyls were above. So you can see there's a lot of similarity between these two chemicals, the only difference between being the ether linkage here. And then down below that, I have the dioxins and the furans, which are highly toxic chemicals that differ just slightly from the ones above. The dioxins have an extra oxygen in here, and the furans are shown here. But the point is that these all have very similar chemical structures. And the PBDEs, which are the flame retardants that I'm talking about, polybrominated diphenyl ethers, are very similar to these and have very similar toxic effects. And laboratory studies now demonstrate that have demonstrated that very clearly, and we're also seeing that very clearly in human studies as well. So the end result of this has been that the major polybrominated diphenyl ethers that were used as flame retardants have been phased out beginning in about 2004. But the lessons learned here, I think, should not be lost, and that is that they were heavily used with widespread human exposures before their toxicity was fully understood. So just briefly, we've learned that infants often receive the highest exposure among various age classes because of breast milk ingestion. We've learned that studies from U.S. adults show significant associations with both dietary levels and dust levels in their houses. And we've learned that the dust in low-income houses has among the highest levels of PBDEs of any that have been studied. And we also have learned that children often have levels that are many, many times higher than adults, undoubtedly because of their hand-to-mouth behavior as they handle things in the homes that are contaminated with the dust. So they get exposed both by inhalation and also by ingestion. And we learned that because of this extraordinary requirement in California, that the levels in California girls in one study were much higher than the levels in girls in Ohio, and levels were higher in blacks as compared to white. So here are some of the health effects of these polybrominated diphenyl ethers, and I'm not going to spend a lot of time on this, but you'll see that they act as endocrine disruptors. They disrupt reproductive function and have developmental effects, for example, cryptorchidism, decrease sperm quality. And the neurodevelopmental effects are perhaps the most troubling and have been reproduced in a number of studies now. This may happen because of the impact of these chemicals on thyroid homeostasis here. Normal amounts of maternal thyroid and then fetal thyroid necessary for normal brain development throughout pregnancy. Studies very consistently now have showed that the children who were exposed to the highest levels of PBDEs during pregnancy had really adverse impacts on virtually every measure of neurological function as they grew up. So prenatal PBDE exposure associated with decreased neurological function throughout childhood. It may turn out that these are permanent impacts. We'll simply have to wait and see. But it made the case that this was not the kinds of class of chemicals that people ought to be exposed to. And so the question is now that they've been phased out, has the problem gone away? Well, the answer is yes, no, and not completely. Here what I'm showing is the results of PBDE levels in 3 cohorts of pregnant women in San Francisco studied during 3 different time frames since the phase out. So you can see here 2008-9 is the blue, 2011 to 2012 is the green, and 2014 is the pink. And you can see levels have declined, but in recent years they've tended to level off for some of these. Here in particular and here, whereas there continues to be a bit of a decline here, and this one has gone down as well. So the question is, are we going to continue to see a decline, or is it really leveled off? And there may be some explanations for this. Some of them, because they're persistent and bioaccumulative, are not going to go away anytime soon from general environmental contamination. But we also have to wonder whether we're still being exposed to them, either because of their presence in recycled products that we bring into our homes, or because of their continued use. So those are all possible explanations for what we're seeing. Well, in many cases, this class of chemicals were replaced with phosphorus-based flame retardants, some of which are also halogenated. And I've shown here the front page of a study that was published in 2011, in which people from all over the country sent samples of foam from baby products into the scientists, who then analyzed them in the laboratory, and showed a wide variety of phosphorus-based flame retardants, which were now showing up to replace the polybrominated diphenyl ethers. So as a result of this, there was a petition that was submitted to the Consumer Product Safety Commission in 2015 called the Organohalogen Flame Retard Petition, which asked the CPSC, the Consumer Product Safety Commission, to ban the use of organohalogen flame retardants in children's products and or in consumer products that where children might be exposed. And you'll see here in the bottom the list of petitioners, and it's an impressive group that got behind this, a group of professional organizations as well as public health and environmental advocacy organizations and so on. And the proposed ban was on the entire class, and I want to emphasize that because it was a novel petition in that regard. Very uncommon for an agency to ban an entire class of chemicals. Rather, they're usually under pressure to take only one chemical at a time, look at it, judge the risk, and then make a decision. Whereas here, it was an entire class of chemicals that would be used in the products that I've shown here on the slide, which includes mattresses and children's car seats and various kinds of infant and toddler products. And on September of last year, the Commission voted to grant the petition. So it was a stunning win in that regard. But then the Commission is required to convene an advisory panel to help decide what the risk is. And so at the moment, this represents a non-binding guidance from the CPSC to manufacturers to stop using the chemicals, but it's not yet binding until a committee that's being convened by the National Academy of Sciences looks at it and establishes the risk associated with it before they will make a final decision in that regard. So I want to just say a few things about the phosphorus-containing fire retardants. As I mentioned, some of them contain halogen, either chlorine or bromine, and then others are either inorganic or organic. There are some that are mixtures of brominated flame retardants and organophosphate compounds. Many of these are additive. So what I mean by that is they're added into the matrix in a way that doesn't chemically bind them. So they can also be released into the environment just like the PBDEs were and continue to be, so that they get into the household environment, into dust, and onto people's hands and so on. Some are used as plasticizers as well as flame retardants, and they have a slightly different or an added mechanism of action compared to the PBDEs. They not only provide free radical consumption, as I mentioned, in the gas phase, but also tend to form a char in the solid phase on something that's burning, which tends to retard the burning of that object. Now, this slide is a mixture of word salad, and I understand that, and I'm not going to get into this in any detail, but I just want to make a couple of general points. There are a number of different kinds of organophosphate esters that are used as flame retardants, and some of them are chlorinated and some of them are not. And among the chlorinated ones, which are the top four in this list here, you'll see that they're all tris compounds, and so you'll sometimes hear people talk about chlorinated tris, and they're talking about one of these that's used as a flame retardant. And then there are some that are not chlorinated, and I've listed them here. But we still have to ask the same question that we ask about the PBDEs and other flame retardants. Are these organophosphate esters going to get out into the environment, and are people going to be exposed? And the answer is yes, they do get out into the environment, and people are exposed. And we know that from studies that have now been done in human populations showing that widespread use has led to their ubiquitous detection in air and dust in the indoor environments. And now we have urine biomonitoring analyses showing that human exposure to this group of chemicals is nearly ubiquitous, with frequent detection of these metabolites of these compounds in people's urine. And we also have learned, just like we learned with the PBDEs, that in children, the hand wipe concentration correlates with their urinary metabolite levels. So kids are getting this class of chemicals on their hands as well, and then are ingesting it or inhaling contaminated dust. Well, what are the toxicity concerns? Back in the 1970s, brominated tris was actually banned from children's sleepwear because of cancer-causing concerns. It's considered to be a probable carcinogen. But then we learned that the industry had simply replaced bromine with chlorine, resulting in the chlorinated tris that I just mentioned to you. Chlorinated tris is considered carcinogenic under the Prop 65 program in California. If we look beyond cancer, the toxicity profiles of this large list of organophosphate flame retardants differs from one to another. But what we've seen in the literature, just to sort of summarize, is they can impact human health as endocrine disruptors and then reproductive and developmental and neurodevelopmental toxicants as well. And I've given some references there, and I've also supplied Becca with a review article for any of those that might be interested, who can look at some of the details there. This is particularly concerning for young children who often have higher exposures, as I mentioned before, compared to other groups, and are a particularly vulnerable time in their development. So in summary, the phosphate flame retardants, we know that exposures are widespread, their safety profiles differ, it should be thoroughly evaluated, preferably before use. We know that some are probably carcinogenic and others have a wide range of negative human health effects. If we begin to look at the alternatives to the chlorine-containing phosphate flame retardants. Some are going to be more problematic than others. Some have a high aquatic toxicity when they get out into the environment. Some are potentially carcinogenic. An interesting one that's being studied quite a lot recently is triphenyl phosphate. It's not chlorinated, but it's likely an obesogen, meaning that it alters adipose tissue development and increases adiposity in experimental animal studies. Others are very persistent in the environment, which makes them a poor substitute for the brominated flame retardants. And then some haven't been well studied at all. And they're showing up in house dust, but the safety profiles haven't really been developed well at all. So the question is, are we really repeating past mistakes in history by releasing poorly studied chemicals into the environment to which people are exposed? So I would conclude this portion by saying, here's some thoughts. We should be asking whether flame retardants are even necessary in a product. And then if they are in a product, how do we know that they're even in there? Are we being told? And what flame retardant's there? If it's in the product, can it be released to the environment? And I've given you many examples of those that are readily released in the environment. And if so, what do we know about their toxicity and environmental fate? And then are less toxic alternatives available for this use? So I think this is a sort of a way to think about this large problem with many, many chemicals involved to help sort out a sort of a systematic approach to thinking about them. So I'm going to stop there just to see if any questions come up while I switch over to the phthalate discussion. Has anything come in on the chat box, or does anybody have any thoughts or questions about the flame retardants?
So we currently do not have any questions. However, we will give folks a minute to see if one or two might come in.
If not, I mean, I can go ahead and we can just get to them at the end. That's fine.
Okay, perfect. Yeah, if folks have questions, feel free to still be chatting those in, and we'll address them at the end of the presentation.
Okay, so I'm going to move on to the other class of chemicals, that group of chemicals that Becca mentioned, that I'm going to talk about, and that's going to be part of some of the campaign work that you all are doing. Phthalates, it's a general term that encompasses two general groups of structural chemicals, ortho-phthalates and tetraphthalates, and I'll explain the difference between them in just a moment. But they're the most commonly used plasticizers in the world, and you can see here in the two bullets that follow just the wide range of products that they show up in. And they're basically used to soften hard plastic so that it can be turned to various functions, and we just see it in many, many areas. And then some of the lower molecular weight phthalates are also used in personal care products. So they're part of our world, and they're very high production, some are very high production volume chemicals, and so we're very interested in them and what their impacts may be. Now, as I mentioned, two general groups, ortho-phthalates and tetraphthalate. And the ortho-phthalates are characterized by having this side chain here come off on adjacent carbons in the benzene ring. So here's a six-sided carbon benzene ring, and the side chain comes off on adjacent carbons, whereas the tetraphthalates, the side chain comes off on carbons that are opposite in the benzene ring. So they're very different, and they have different toxic profiles and very different uses in many cases. But it's an important distinction to keep in mind. You may know the most popular terephthalate is polyethylene terephthalate, abbreviated as PET, which is used to make many plastic throwaway bottles, unfortunately. It's a polymer of polyethylene terephthalate. And then it can be turned into polyester textiles as well. Now, among the ortho-phthalates, so now we're going to concentrate. We're going to concentrate on those, on the ortho-phthalates, for the rest of this presentation. And what we'll get into a little bit here is the difference in the side chain here that comes off, because it has real impacts in terms of its use and its toxicity as well. You'll see at the bottom, for example, this is dimethyl phthalate, in which the side chain is really quite short and only has a methyl group attached to it, where here's just another example of diethyl hexyl phthalate, DEHP, which has a much longer and more complex side chain attached to it. But in both cases, they're ortho-phthalates because the side chain comes off of adjacent carbons. They have different uses and functions and characteristics depending on the nature of that side chain that comes off of it. So there are low molecular weight ortho-phthalates like this one, and then there are sort of mid-range like this one, and then there are some very high molecular weight phthalates that have 7 to 13 carbon atoms coming off of this side chain here. And they're made and used in different ways because of the properties that imparts to the molecule. Well, exposures to these chemicals are really ubiquitous in the general population. And we know that from some biomonitoring studies that have gone on for some time. So on the right here, I'm showing you results from the national U.S. National Health and Nutrition Examination Survey, so-called NHANES, which is conducted by the Centers for Disease Control on a regular basis. And what they do is they assemble a representative population of the United States and then do biomonitoring studies. And then those are publicly available, and you can go to the CDC exposure report and get the results there. But what I'm showing here is there's been a slight decline in some of the phthalates in recent years. If you compare 2009-10 results to just a couple of years earlier, you'll see that there's been a decline in some of them over that time. The parent compound, for those who are interested, is listed over here on the right. But there has been some decline, and I think that decline is probably due both to emerging scientific concerns, but also to a lot of public pressure, which various groups, organizations, advocacy efforts, campaigns have been working on for more than 20 years to point out that exposures are widespread, and the more the science develops around these ubiquitous chemicals, the more we're concerned about them. So the exposure pathways will sound similar to you. Ingestion is a major exposure pathway, and in fact, food is probably the most important for many of the phthalates mentioned. And Becca mentioned at the beginning in her introductory remarks how the mac and cheese study, for example, is just one product that has had phthalates in it, and trying to find out how they got in there, because if milk processing equipment, for example, using plastic tubes that are plasticized with phthalates, gets into the processing chain, then that's one of the important sources, undoubtedly. So this is all trying to be understood. Inhalation is an important pathway. The phthalates are semi-volatile. They get out into the environment. They're clearly present in house dust and so on. People can inhale it. And then dermal absorption is important for some of them because of the molecular size and characteristics. They can be absorbed through the skin. And if they're in personal care products, that's an important pathway of exposure. So in terms of their toxicity, I had to summarize just a whole lot of literature here in just a couple of slides. And I just wanted to give you sort of a flavor of the kinds of things that are showing up without getting down into the weeds too much with respect to each particular phthalate. But we have hundreds of animal studies that document a number of kinds of toxic endpoints and health endpoints, for example, in the liver, kidney, testes, and thyroid. And then we have many dozens of studies in humans, some, but not all of which show effects consistent with the effects in animals. And there are some important differences One of the most important being, or one that's most contentious being, that some phthalates clearly are cause of liver cancer in rodents, but through a mechanism that many people believe is not relevant to humans. That's still debatable, but that's one that stands out, whereas many of the other health endpoints are thought to be relevant to humans, although the susceptibility and the dose response curve may well differ from one species to another. The biochemical mechanisms are known for some of these effects, particularly with respect to impacts on the male reproductive tract. Sertoli cell toxicity is an example, the Sertoli cells being the source of testosterone synthesis. So we actually see impacts on testosterone levels related to exposure levels. And then some phthalates act as endocrine disruptors, interfering with testosterone expression and thyroid function, which may explain some of their observed effects on intellectual function and behavior. So here's just a chart that I took from the CPSC, the Consumer Product Safety Commission. You could just sort of see here, this is the various lists. So as you go from the top here to the bottom, you're going from the low molecular weight phthalates to the higher molecular weight phthalates as you move down here. And you can just see wherever there's an X in a box, the adverse impact has been demonstrated for various toxicological endpoints on sexual development, reproduction, thyroid, testis, kidney, and liver, and so on. So you can see that whereas there's some variability from one phthalate to another, the health impacts have really been seen in a whole variety of different organ systems. In people, the impacts of prenatal exposure to some, but I want to emphasize not all phthalates because there are differences among them. We've seen reported an increased risk of preterm birth, interference with the development of reproductive organs, which is consistent with what's been seen in animal studies, although I want to point out here that the evidence in people is inconsistent from one study to another. So they don't all show this, these endpoints. We do see increasingly in the literature and fairly consistently an impact of phthalates on intellectual function and social behavior and impulsive behavior in children. So that's really getting more and more attention. And then more recently, some evidence that prenatal exposures are associated with an increased sensitization of the immune system, which may explain some of the association with increased allergies and asthma that's been demonstrated in children with higher levels of phthalate exposure. I want to point out here that just in general about the phthalates, that these are short-lived compounds. We're exposed to them and we metabolize and excrete them fairly readily. But because we are continuously exposed to them from a variety of sources, we never sort of get away from some level of exposure. But the level certainly goes up and down. And this creates real challenges for doing epidemiologic studies, because if, for example, you wanted to measure the impact of phthalate exposure in pregnancy to birth outcomes, you would have to figure out how best to estimate exposures during pregnancy. And if you just take 1, 2, or 3 maternal urine specimens throughout a 9-month pregnancy and measure phthalate levels and their metabolites in the urine, that's giving you a snapshot of what the phthalate levels were at that moment, but doesn't really give you an integrated view of what phthalate exposures were throughout the pregnancy. And moreover, because there are different windows of vulnerability during pregnancy, exposures during one day or week or period of time during pregnancy might be much more consequential than others. So it represents a real epidemiologic challenge. And it may help explain some of the inconsistencies that we're seeing in literature, such as I had mentioned here, in terms of their impact on the male reproductive organs and on brain development and function in kids. If we look at impacts of childhood and adolescent exposure, some studies have shown that some phthalates are associated with advanced pubertal onset in girls. And that may also be related to prenatal exposure. But I should have put here, and I didn't, that these findings on excuse me, sorry, inconsistent. And the authors of each of these studies have said, you know, it looks like it's important when we measure exposures, because there may be times during early childhood when exposures are much more consequential in terms of age of puberty than others. So again, it's this problem of trying to figure out what exposures really are, which may help explain some of these inconsistencies. We're clearly seeing an increased risk of asthma associated with higher levels of phthalates on indoor dust. That's been shown in a number of studies now. I think it's beginning to be accepted as likely to be a causal relationship, although I don't think it's been universally accepted. And then some studies are showing that certain phthalates are associated with increased insulin resistance. And I've given you here some references of review articles that take a huge amount of literature and summarize it in a way that you might find more digestible. And then finally, a number of epidemiologic studies have shown that there's a correlation between higher levels of certain phthalates and impaired semen quality in adults. So these studies have been done in men who are being studied for infertility and men who have not been, but looking at various measures of semen quality and seeing how that compares to phthalate levels in their urine. So in 2016, the Food and Drug Administration was delivered a petition that was asked through a petition to revoke 29 ortho-phthalates, this whole family of compounds in food contact material. And you'll see here who filed that petition, and it's a group of public health and environmental organizations concerned about public health. And this was a petition that asked for all of the ortho-phthalates to be removed from food contact material. And it's still under review at the Food and Drug Administration. But meanwhile, the FDA went out and did their own study of phthalates and other plasticizers in food packaging and processing equipment. And I've just given you the summary here of what they've published. They found that there are 9 different plasticizers, including 3 phthalates, identified in the products they tested. And then you can see that the concentrations range from small up to 50% of the product, depending on what it was being used for. And overall, they concluded it appears that manufacturers are switching away from phthalates as their primary plasticizer in food packaging and processing equipment to alternative compounds. And I've listed some of those alternatives below. So it looks like this concern about phthalates is having an effect in what is already happening in the marketplace. But the levels, the phthalates are still there, and the Food and Drug Administration is still considering this petition. So in summary, ortho-phthalates are extensively used in many products. Exposures are ubiquitous. We have evidence that's emerged over the last 15, 20 years of a wide variety of adverse health effects, and advocacy efforts and government reviews have helped slowly to shift patterns and profiles of their use. But we also have to ask, once again, just like with the flame retardants, are alternatives safer? In some cases, yes, but not always. And in some cases, we don't know because the alternatives haven't been as widely studied. So it's a similar set of questions that we have with the flame retardants, and lots of opportunity to weigh in and participate in the decisions that are finally made around this large family of chemicals. And with that, I think I'm finished, Mara, and happy to turn it back to you.
Perfect. Thank you so much. So now we are going to be opening it up for some questions from the audience. I know we've had a few come through, so we'll start with what we have so far. So, Dr. Schettler, can you talk a little bit more about the importance of the timing of exposure to either phthalates or flame retardants?
Yes, let me start with the phthalates. I'll use DEHP, diethyl hexyl phthalate, as an example. It's one of those that we know can impact the male reproductive tract development. And so then the question was, well, when during pregnancy is the male reproductive tract developing in ways that it can be derailed by the exposure? And so you can sort of look at the at that question. We know I'm not going to try to remember the days or the week exactly, because I'd probably get it wrong. But we know during the important time during human development in utero, when the reproductive tract is differentiating from the female to the male morphology because of the hormonal drivers of that phenomenon. And if the exposures occur during that window of time, it's more likely that the male reproductive tract will be derailed. With respect to the impacts on the brain, of course, brain development is going on throughout pregnancy and childhood, and depending on when that exposure occurs, it will have likely to have a different impact on brain development and function. And so we see in both studies of the phthalates, but also in the flame retardants, depending on the timing of exposure or the amount of exposure, the impact on brain development and function would differ. It might be a behavioral effect. It might be an intellectual effect. It might have and various aspects of psychomotor function and so on. So the outcome will depend on what's going on at that time and during development, whether it's the male reproductive tract or the brain.
Great, thank you. So our next question is, as an advisor to Healthcare Without Harm, can you talk a little bit about health professionals' role in various campaigns that have led to some of the reductions we've seen in some of these chemicals over time, or maybe an example from your own advocacy work?
Yes, I'd be glad to. The health professional's voice is very important in this work. And there are a number of ways to do it. So, for example, I'll use the Healthcare Without Harm and DEHP example to illustrate. When we became aware of all the medical products that are made out of polyvinyl chloride that are plasticized with DEHP, we then learned that DEHP was leaching out of many medical products so that the patients were being exposed. And in fact, a number of years ago, Healthcare Without Harm co-sponsored a study that we did in 2 hospitals in Boston. One was Mass General Hospital and one was Brigham and Women's Hospital, in which in the neonatal intensive care unit, the urine from babies that were being treated there was collected and analyzed for the DEHP metabolites. And we were able to clearly show that these young infants were being exposed to DEHP from the medical products that they were being treated with, and that the babies that had more intensive care with more PVC products involved were being exposed to higher levels of DEHP. So we published that paper in Environmental Health Perspectives, and it was purely an exposure study. It was not intended to say or look at all anything about the health effects, but we wanted to show, document, understand what the levels of exposure were. And that was a very important study because it stimulated more look at exposure levels, and then people began to say, well, you know, how do these levels compare to what we're seeing in where animals are exposed in the laboratory, and what are the adverse health impacts? So with that work done, we then were able to go to various medical associations, and we started at the state medical association level and then built toward the American Medical Association, looking for resolutions that would recommend that PVC products that were plasticized with DEHP be avoided where possible, without, of course, withholding important medical care. That was not the purpose, but the idea was to shift the market to using safer materials when making these medical products. We also had a market-based campaign with Baxter Healthcare and with what was then Abbott, which were two of the major manufacturers of polyvinyl chloride bags and tubing that are used throughout healthcare, and worked to get Abbott actually in one of their sister organizations actually began producing a tubing that was entirely free of DEHP. It was replaced with a different plasticizer. And then Baxter soon followed by creating an entire line of bags that were no longer made out of PVC at all, but it was an alternative polymer. Baxter did not take PVC out of the product line, but they created an alternative line for people who wanted to do it. So I think that the take-home message is that there's an important role for healthcare professionals in helping to expose the problem, explain the problem, and then doing advocacy with their health professional, their professional organizations, whether county medical societies or state medical societies, and then working toward national efforts to try to influence the market, whether it's around DEHP and phthalates or any one of these others that we've talked about.
Great, thank you. So our next question is regarding asthma. Do you think the association of phthalates with asthma risk is beginning to become more well known by clinicians treating children with asthma?
I think it's beginning to be more well known by some clinicians, but not by most. I'm working closely on an effort with primary prevention of asthma in Massachusetts, which we hope will gain traction in other states around the country. The idea is to try to identify the risk factors for asthma that we can do something about, and then try to make change. And among the people who are working on this in Massachusetts, there is real awareness of the role of phthalates and the potential role of phthalates in asthma risk. But how to develop public policy around it is very difficult. And what's happened, I think, mostly has been that clinicians are recognizing that asthma prevention and reducing the severity of asthma attacks in people who already have asthma can be accomplished by some behavioral changes in the house. And one of the most commonly talked about is taking your shoes off when you walk into the house so you're not tracking in contaminants from outside. And then a lot of attention to proper cleaning in the house, both vacuuming and dusting and so on, with a recognition that you're picking up dust that is contaminated by a number of potentially hazardous chemicals that may not only be associated with asthma, but also with other health endpoints. So I think that many clinicians are using that kind of approach with patients to talk about behavioral change that they can make in their homes that will address a number of risk factors, including asthma, for risk factors for diseases, including asthma, where cleaning is an example of one that will certainly pick up the phthalate issue. But I don't think that the phthalate asthma connection is yet widely recognized beyond that.
Okay, and so actually our next question kind of ties into that. So do you have recommendations for clinicians on how they might talk with patients about these chemicals? And are there particular occupational exposure risk, for example, that clinicians should ask about when speaking with patients?
Well, there are a number of guidelines that have been developed or recommendations that have been developed by various groups for how to talk with patients about this, and one that I would suggest, the program on reproductive health and the environment at UCSF. So if you just go to the program on reproductive health and environment website, you'll find some really useful fact sheets there and easy to digest things that give recommendations for how to talk with patients about this. Because one of the problems, of course, is that you can end up scaring people to death from virtually everything that's around them. But there's some sort of systematic ways that you can approach this, so you can get a bigger bang for the buck. So, you know, some of this stuff has to be just sort of common sense about cleaning and hygiene. But getting beyond that, you can also talk about things like pesticide use and whether the pesticides, if pesticides are being used, are they even necessary, and are there better ways to control pests in the house? You can talk about products that people are buying and bringing into their homes, but you know, you can't shop your way out of this problem. That's why these market campaigns are so important, because we all in our homes have a lot of plastic objects that are undoubtedly leaching phthalates and other chemicals into our indoor environment. And the best and really only effective way, beyond cleaning up the contaminated dust after it's already been exposed, is to have the chemicals taken out of the product, so we're not bringing them into the homes. And that's exactly what happened with the flame retardants. You couldn't control what flame retardant was in the cushion on your sofa, but the agencies that regulate those products certainly could, and they did. And by getting this phase out of the PBDEs, it's made a real difference in terms of what's in our indoor environment. So I think the market campaigns have to go along with the individual behavioral things. Occupational risk, absolutely important. And, you know, clinicians should routinely be asking about occupations of patients and their family members, because that will help direct where the attention should be paid. And I mean, we know, for example, of many stories of people exposed to lead in the workplace and bringing it into their homes, of being exposed to pesticides in the workplace and agriculture and bringing them into their homes. So we clearly need to be asking that question, and then depending on what we learn, figuring out what the best intervention would be. So yes, I'm a big fan of taking environmental histories, which includes an occupational history, and then based on that, you can tailor recommendations to individual patients.
Okay, so our next question is, as a provider, what is the best recommendation for assessing children if they have many of the symptoms that you addressed in this presentation?
Well, with children, I addressed a number of endpoints. So let me talk about, maybe the question is around the neurodevelopmental, because that would clearly be different from the birth defect thing. I take a very ecological approach to this, meaning I put the environmental chemicals in context with a number of other things that can influence child's neurological development, including nutrition, including social stressors, family dynamics, and so on. We know, for example, that adverse child experiences, ACEs, have a major impact on children's neurological development and behavior and their disease risk throughout their lives, really. So while we're learning about the environmental exposures that we're interested in, well, we also have to be asking and learning about whether or not children are being exposed to other adverse environmental stressors like, family violence, abuse, neglect, and so on. The things we're familiar with and should be very interested in, because addressing those up front is going to pay off in a major way. and nutrition as well. We know that certain aspects of nutrition are vitally important for normal brain development and function. So I don't separate these out into hierarchies so much as trying to address the various categories of environmental factors. And when I say environment, I really do talk about the chemical, the built, the social, and the nutritional, the food environment, and their interactions, and figure out ways to, in a very streamlined way, because clinicians' time is limited. I get that, and the pressures to move on are enormous. But I think that every clinician needs to sort of find their comfort zone with what group of pilot questions, of screening questions, will trigger more in-depth investigation, depending on what the answers are. So things about what children are eating and what the family dynamics are at home. And there are some very good and fairly quick screening level questions you can ask about the indoor environment in a home that will lead you to wonder whether you ought to be digging more deeply around various chemical exposures. So I see it as sort of a mixture of those that that should be routinely engaged in taking a history in general. And then the other thing to point out is that some of these are community level exposures. So, I mean, your experience in Michigan with the Flint water crisis is an example. But you know, if you're practicing in Flint, Michigan, and you knew what was going on there with water contamination with lead, you certainly would be more worried about lead contamination there than in some other places. But as you also know, other cities are not off the hook. The Flint crisis has really exposed water contamination with lead throughout the country, and has led to a lot of action. So we can't assume that just because we don't know about lead contamination in our community, it isn't there. But the other thing that around the Great Lakes, for example, you'd want to ask about fish consumption, because many of the Great Lakes fish are contaminated with legacy chemicals that can be problematic. And if you have a family that's consuming huge amounts of fish, you would want to know what they are, what fish they're eating, and whether these are ones they should be eating in that amount. That's not to say that fish isn't healthy, because it is, but in areas where the fish is contaminated, it's really an important question to ask. So I think the community context helps to sort of organize the questions that one might want to pursue in a particular practice in a particular place.
Okay, so we currently have one more question left. I'm saying this just to let folks know that if they do have questions, now is the time to get them in. But the question is, do you know if testing at the time of admission or during an exacerbation for a toxin is possible, or if it's meaningful to do?
Yeah, it's an important question. The answer is it depends, and usually probably not helpful. It would depend on the specifics, however. So at the time of admission, when somebody comes in with acute symptoms that might be related to a toxic exposure, it's a great time to take a look, depending on what the toxic exposure is. I mean, I can recall in my own practice a number of years ago seeing a man in his 60s, as I recall, who had a history of imbalance and a fall, and some other sort of neurological kinds of stories in his history. And it turned out he had a history of, he was a house painter, and I got a blood lead level on him, and it was sky high. So that would have been an important one not to miss. So I think it's the, oh, you don't want to miss it, exposure that you want to be looking for at the time of admission. If you have something that's chronic, that might be due to an exposure that occurred over time or years ago, it's going to be less helpful. So it really depends a lot on the nature of the symptoms and whether they might be explained by an ongoing exposure that would help you decide whether to do a blood test or a urine test or something at the time of admission to see if it's related. That might well help with things that are likely to hang around in the blood or the urine. If you had exposures that were very short-lived, where even if it were responsible for the symptoms, it's now likely to be gone, then not finding it is not going to be very helpful. So I think it would depend a little bit on the symptoms, and then the chemical that might be responsible for it would help you decide whether you were going to be ordering a blood test or not. And there are some guidelines for doing that. There are occupational health textbooks have some suggestions in them, and if you did want to monitor for something, what would you actually ask for? If you were concerned about somebody's exposure in the workplace, it might be that doing the biomonitoring is not necessarily the first step as getting a better history of what somebody's exposed to in the workplace. So if you think it might be an occupational exposure, then you would begin to collect information on what the person is exposed to in the workplace. For children, of course, then it's not going to be a workplace issue, but it's going to be more a school or home issue, and that would help guide your thinking about what you might test for. But I guess what I also want to just caution you about is that you can spend a lot of time and effort and money on tests that aren't going to be very productive. So it should be thought out and decided on a case-by-case basis. And also, children's environmental health, or the children's PESHUs, where the pediatric environmental health specialty units, can be helpful for advice on particular cases if you have a question that you want some help with the answer.
Wonderful. Thank you so much for answering those questions. It looks like we don't have any more that are coming in. So with that, I just want to take the time to thank you again, Dr. Schettler, so much for presenting to our fellows. We really appreciate it.
My pleasure. Thank you.
And with that, we'll kind of wrap up today's presentation and webinar. Really quickly, we do want everyone to be aware that our webinar evaluation is required for all Health Leaders Fellows. And we also strongly encourage all other participants to complete the survey as well, as your feedback is valuable in planning future meetings. And you should all have received a link just now that includes the evaluation. When we send out the recording of tonight's webinar, we will also include the evaluation link. And as a quick reminder, our next webinar is taking place a week from today. It'll be our media training webinar. So it's part one of our two-part media training. We'll be joined by our presenters, who are Denzel McCampbell from Engage, Michigan, and Sam Inglot from Progress, Michigan. So like I mentioned before, that webinar will take place next Tuesday, June 19th. At noon, and registration link is right there. That information can also be found on our website, and we will also be sharing more details about that later this week and into next. So with that, I'd just like to take a second again to thank Dr. Ted Schettler for taking the time to join us all today for a wonderful presentation, and thank all of you for joining us for today's webinar. Enjoy the rest of your evening.